Welcome to Safety Spectrum, your environmental health and safety connection. This program is a presentation of the Michigan Safety Conference. For almost a century, the annual conference has provided credible educational opportunities and valuable support to the safety and health practitioner by offering 120 instructional programs along with exhibits highlighting the latest in safety equipment, instrumentation, and demonstrations. To learn more about the conference, please find us at safetyconference.org. Welcome to Safety Spectrum. I'm your host, Sheila Ide. This program is sponsored by the Michigan Safety Conference, and our topic today is work-related lung diseases. Employees are exposed to many hazards in the workplace. One of the most insidious diseases are ones that affect our respiratory systems, leading to a possible lifelong disability. Our guest today will explore this topic in detail. Our guest is Dr. Kenneth Rosenman, Professor of Medicine and Chief of the Division of Occupational and Environmental Medicine at Michigan State University. Dr. Rosenman is board certified in internal medicine and occupational and environmental medicine. He is a fellow of the American College of Epidemiology, the American College of Occupational and Environmental Medicine, and the American College of Preventive Medicine. He is a recipient of the MSU and the College of Human Medicine Distinguished Faculty Award. Dr. Rosenman has directed the Occupational and Environmental Health Team at MSU for the past 36 years, which has worked closely with the Michigan OSHA program and Michigan Health Department to administer Michigan's occupational injury and illness reporting regulations. Of particular interest to Dr. Rosenman is lung disease caused by work exposures, and he has published over 200 articles on occupational and environmental diseases. Thank you for joining me today on Safety Spectrum.
My pleasure. Good to see you.
Good to see you too. Why don't you talk a little bit about what your team does? Highlight.
Sure. So we're at Michigan State University. We don't have any regulations, but the state, both Michigan OSHA and LEO and the Michigan Department of Health and Human Services has occupational disease and injury reporting regulations. And so we administer those regulations for the state. We get reports directly from hospitals, emergency departments, acute care, urgent care centers, the poison center, and then we compile that data and we issue annual reports. We use the data for educational reasons. We get back to Michigan OSHA when we see things that could be prevented. And, I'll say it now and probably at the end, but all our information is on our website, which is oem.msu.edu. And you'll see 36 years worth of annual reports and hazard alerts, because I've been doing this a long time. And I do want to say hello to all the industrial hygienists and safety people out there who may be listening, who I've interacted with over the years. I'm still here, I'm still working, and I'm enjoying it very much.
That's good. And you could also identify trends, I imagine, if you add it to a national database.
We do identify trends, and I think that's one of the reasons. So what we do is funded by NIOSH, by the federal government, and we emphasize that we can look at trends. And the other reason I think we keep getting funding is when we go directly to the hospitals and to the emergency departments, and in a way, so we're not dependent on an employer reporting. We see twice as, depending on the condition. Well, let's take amputations or crushing injuries or burns. We see 2 to 3 times as many work-related injuries from the medical record. So many employers are not doing a good job reporting either to BLS or on their OSHA log. So we now have new electronic reporting directly to OSHA, but that only covers certain industries. So we see a lot more reports, even with hospitalizations, right? Employers now have to report hospitalizations. We just published a paper to say, when we look at the hospitals themselves, there's twice as many work-related hospitalizations than the employers are reporting.
Oh, that is interesting. So what are the most common work-related lung diseases in Michigan, and do OSHA PELs protect against their development?
Yeah. So, I think, historically, we know about asbestosis. Silicosis has been known for a couple of thousand years, and We still see people getting silicosis. But the lung diseases that are more common now are diseases that many safety industrial hygienists may not associate with work, and that's asthma. So up to about 30% of asthma is work-related. And actually, if you include asthma that's aggravated, not caused by work, it could get up to 50%. So there are over 300 substances known to be used in the workplace that cause asthma. So not just aggravated, but somebody who's never had asthma now gets asthma. So some are really obvious, right? Take the veterinarians. They become allergic to their patients. Okay, they become allergic. Same way people become allergic to dogs and cats in their house, the vets become allergic to their patients. Or you can have researchers in a mice or rat lab, and they become allergic. Then you have plant products, so people can become allergic to certain tree species or florists. Or think about latex rubber. It's much better now, but in the hospitals using latex gloves, well, that's really a plant product, right? It's tree sap. But what we're seeing now as the common causes of work-related asthma are various chemicals. So in the past, it's been isocyanates, but we've learned better how to use isocyanates. But take particularly with COVID, a lot more disinfectants being used. So your quaternary ammonium chlorides, we have them in our home, but we're using a lot more, not only in healthcare, but daycare and hotels and wherever. Those are allergens. People literally, the same way you can become allergic to grass or tree pollen, you can become allergic to the quats. You can become allergic to bleach. Bleach is commonly used. And so there are substances like these, and though your question was, well, do we have occupational health standards. There is no occupational health standard for bleach. It probably, I guess, would be, I don't know what it would be treated as, a nuisance dust, but there is no, and so we have many, be it federal or Michigan OSHA, where there is no regulation, or sometimes, think about bakeries. So people become allergic to flour, or they can become allergic to various mites or bugs that live in the flour. Well, flour is treated as a nuisance dust. And so that's well above the level that people can become sensitized and become allergic. So the standards, I mean, I see it all the time. An industrial hygienist, you'll have somebody with work-related asthma. The industrial hygienist goes back, does sampling, does good sampling, it's done well, and they'll say either it's below the OSHA standard, or or there is no standard, or they'll measure something else, which they hope is a surrogate. The other thing, even for the isocyanates, so we do have a air standard, a PEL, but for none of the occupational allergens, these over 300 substances, none of them have comprehensive standards. So we have a comprehensive standard for silica that requires medical surveillance, but we don't have for any of the occupational allergens. So at one point, we came real close with the isocyanates. Michigan was going to lower the PEL in Michigan and have a comprehensive standard. And it went through public hearings, and at the last moment, various large manufacturers decided they didn't want to see this standard in the state. And this is about 20 years ago, and we don't have it. So I spent a lot of time talking about asthma because it's now become the most common work-related disease. Asthma is very common. We have 900,000 people in the state who have asthma, and people think of asthma as a child disease. But if you look at the 900,000 people in the state, 600,000 of them are adults. So asthma is the most common chronic disease in children, but a lot more adults have asthma than children do. So we have
I was,
600,000 people in the state with asthma,
I was going to
adults.
ask you that if children are getting it from exposures that their parents are in an atmosphere, or it starts in childhood
Yeah.
from other sources.
It probably starts from other sources. Sometimes it might be an acute viral infection. Sometimes it may be substances their parents are using in the house. There is, we know about take home lead, take home mercury in cases of that. I'm not aware of anybody's ever reported a take home asthma case, where somebody's,
Right.
let's say worked in a bakery and is covered with flour when they come home and gotten their child. I've never seen that reported. It's interesting and it certainly could be possible, but I can't say I've ever seen that reported in the medical literature.
And maybe I'm taking a giant leap, but can I extrapolate from what you're saying that everybody's going to get sensitized to something if they work with it all the time? Or is that
No, just the opposite. I'm glad you asked that question, and because others probably have that question too. So if you look at good studies, and let's say there were some great studies done with the isocyanates, right? And we use a lot of isocyanates in the state, right? Our car seats were manufacturing various other, the headrest, various other parts, and so before controls were instituted, 5 to 10% of the workers would become sensitized to isocyanate. So it's a small percentage. Ideally, you could have a medical program to identify who would become sensitized, but none of the studies have been able. So you'd say, this person already has allergies. Maybe they shouldn't work with isocyanate. Or this person is a cigarette smoker. Maybe they shouldn't. But none of those studies panned out. So no, we don't have a way. I mean, the best way to prevent work-related asthma is keep those levels low. There's one other exposure. I mentioned cleaning agents, but something that I'm sure the industrial hygienists are coming across, welding is the fumes from welding cause asthma. So somebody can get asthma from welding. And so that's another example of something certainly very common. And maybe if I can keep talking, I'm going to lead from asthma to COPD. Can I keep talking, or did you have a question,
Sure, go
Sheila?
ahead. I'm just saying with welding, of course, you're dealing with a lot of different substances, different metals. So I mean
Right,
the possibilities are endless, shall we say. So
right,
COPD.
right. But at one point we thought it was just stainless steel welding. I haven't gotten to see COPD here, but now it's welding, all welding, and it could be the flux, it could be the metal itself. But COPD, I mean, clearly smoking causes COPD, and nobody should be smoking. And the data is not in on vaping yet, and it's probably a little less harmful, but vaping's not good for us. But smokers who are also exposed to chronic welding fumes increase their risk of COPD. So when I say COPD, I'm talking about chronic obstructive pulmonary disease. Many of us know it as emphysema, same thing. And so now this is not an acute disease, right? So I weld for 20, 25 years. Their controls aren't good. I also smoke cigarettes, and the combination, I am much more likely to get COPD than just welding or just smoking. Now, there are some people who just weld and get COPD, but if they've also smoked or continue to smoke, they're much more likely. But that's
Yeah.
a chronic condition, unlike the asthma, where typically if you're going to become allergic to it, it's within the first 2 years of going to work.
Right. It's not a scientific survey, but it's always been my impression over the 40 years I've been in the business is that a lot of construction workers, they don't die necessarily of accidents, but they end up with some kind of disease. So that
Right.
keeps them from physically able to do the work. So a lot of
Well,
the
so clearly you have lots of musculoskeletal, right? You got a strenuous occupation, but we're talking about respiratory. So
right.
historically, we got asbestos, right? and there, there's a strong synergism interaction between cigarettes and asbestos, increasing lung cancer, but there's also the issue of COPD with all the dust. And then, construction workers are using isocyanate. Is it, depending what they do, is it a spray on urethane, or is it, insulation, foam insulation? So yeah, construction workers have increased risks, and particularly again if they smoke, and it's been a population that's had a higher prevalence of smoking than, let's say, doctors don't smoke anymore, or
I used
if
to do
they do,
commercials when I was a
if they
kid.
do, they smoke in the closet, so you
There
don't
you
know.
go. Okay, we'll shift gears a little bit. What are the effects of mold and what is the best way to assess for their exposure?
Yeah, so there's a lot of hype about mold, and people get very concerned about mold. And mold is one of those things that can cause asthma. It can cause allergic rhinitis, which is just stuffy, runny nose. Um, then there's an unusual condition that is more like, um, it's a fibrosis. So it's more like asbestosis. It's called hypersensitivity pneumonitis. And so there are these respiratory issues. And for this, particularly the asthma, the allergic rhinitis, um, if you're already allergic, you're more likely to have a problem with mold, be it mold in your home, be it mold in an office space. But what's out there and really is misleading is this whole issue of toxic mold. The issue of black mold or Stachybotrys comes from a CDC study in the early 2000s where they did a study of newborns in Cleveland, and they said there's increased mortality. These kids, these babies were dying from Stachybotrys, black mold. And that got out in the press. About 2 years later, CDC said, oh no, sorry, we made a mistake. It had nothing to do with the mold. But ever since then, people are just so fearful of Stachybotrys and mold. Um, and this toxic mold, if you Google toxic mold, you will get 1 million hits. Many of them are attorneys, who want to represent people. But toxic mold, the data on toxic mold is mold, if you ingest food that's moldy, potentially you'll get an effect. But the toxic mold in the air, it's just not an issue, and you don't have all these conditions that you'll find on the web. So I see lots of patients who are they think they're going to die tomorrow from the toxic mold they've been exposed to. And if they don't have the lung disease, um, I guess I didn't mention there's one more. I mean, if you're immunosuppressed, you got cancer, you're on high doses of steroids, then you may get an infection from a mold. Or, sometimes, I don't know, Sheila, if you've seen it, that we had this big outbreak of blastomycosis at a paper mill in the UP,
Yep.
where 120 people got sick. And so they
Right.
didn't have any underlying disease, but they had enough exposure to the blastomycosis in the paper mill and got it. So you see that sometimes. But generally, we're talking about an allergic condition, and people, and again, that the blastomycosis was not a toxic mold
That
issue.
could be a controversial stand, what you just said.
I don't. It could be controversial with the internet. It's
There you
not
go. Very good.
It's not controversial with
With
CDC.
science.
It's
Right.
not controversial with all the medical societies, with the allergists, the internists, the occupational environmental medicine physicians. You're right. It's not controversial with the scientists, but it is controversial with the internet.
So,
Yes.
like everything, if you've got underlying conditions, certain things will add to the problem.
Right. So the concern, if you, let's say you had cancer or you had a connective tissue disease and you're on high doses of steroids, you might get an infection from the mold. but you're going to get very sick. And the doctor's going to be able to diagnose that. So it's not like, oh, I got a headache and I'm fatigued and I'm irritable. I must be toxic mold. You're either going to be very sick, and then we have some healthcare providers who'll say you have mold growing in you, and they will sell you all kinds of medication from their office, not covered by health insurance. People are spending thousands of dollars for the assessment and thousands more. And then they're spending, I had one patient who spent $20,000 renovating her home because of toxic mold. I mean, there's a lot of scams out there, both, I won't say the industrial hygienists who are listening to this, but there are people going out. I'm aware of one group of consultants. They'll go to elderly individuals and say, we'll check for mold. And they always find mold because mold is everywhere. And then they'll say, don't tell anybody, don't tell the local health department, don't, they'll come and they'll shut down your home but we'll fix it for you. We'll remediate it for you. And here you got to give us $10,000. There are these scams where people are really being taken advantage of.
That's too bad. Well, then I'm going to go off in another direction. What about
Okay.
histoplasmosis related to
Okay.
bird droppings in that?
Yeah, so certainly, and so blastomycosis, is in soil and wood, and but certainly you mentioned histoplasmosis. So you'll see it in bird droppings. So there was an outbreak in the Muskegon area a number of years back. There were lots of pigeons on the roof, and the workers were told to go clean the pigeon droppings, and there was an outbreak of histoplasmosis. Um, we've also seen it in construction workers. There the fort in Mackinac. You got, let's clean out the chimney, and you got bats, right? So it doesn't have to be birds; it can be bat droppings. And generally these are diseases are relative. Lots of people, like even in the blastomycosis in the UP that just occurred. Yes, one person died, 13 people were hospitalized. Most people were okay, and there were another 25 people who became infected who had no symptoms. So there's a real range of how people can react. But blasto, histo, and we're not in the area so much for coccidio. That's a condition in the Southwest, but you see that in people putting solar panels out in the desert, and they're construction workers getting coccidiomycosis, or there's another report of they were filming I don't know, maybe it was a Western, I don't know, but it was out in the desert, and the actors got coccidiomycosis.
Wow. Just wow. Kind of a crapshoot there. So we protect everybody from everything, basically.
Well, no, come on,
Well,
these are
we don't
basic.
know who's going to be susceptible. That's what
No,
it
but
comes
these are
down to.
basic industrial things.
Sure,
You
sure.
go into a confined space, a chimney,
There
you
you
want to
go.
have respiratory protection.
There you
Um,
go. That's what I wanted to hear. Yeah.
Yeah, dust suppression. You need dust suppression. If you're out in the desert building solar panels, you got to suppress, you're digging and you're putting in the foundations of the solar panels or whatever they were doing on the movie scene. They then, started doing dust suppression so people aren't inhaling the stuff. I don't think the actors wore respirators.
Yeah, probably not, especially not in the film. So
Right.
we'll switch gears again. Is it useful to perform breathing tests as part of the required medical certification to wear a respirator?
Yeah, so there's again, you got me on misinformation here. Okay, so um, OSHA, both federal and Michigan OSHA, requires a questionnaire, and they actually have the actual questionnaire as an appendix. And that is the only thing that's required to approve somebody for a respirator. So a healthcare provider has to review that. I'm pretty sure it says a physician, but it could be a nurse practitioner working under the supervision. So the physician does not have to review every one, but maybe only reviews the ones where there's some questions. There's no requirement for breathing tests. There's certainly no requirement for chest x-rays. There's no requirement for a physical exam. So for example, we have 12,000 employees at Michigan State University. We have healthcare workers who are wearing N95s. We have maintenance people wearing respirators. We have, maybe almost 2,000, be them plumbers, electricians, masons. And we don't do breathing tests on people unless there's something in the questionnaire that suggests a breathing test should be done. We certainly would not do x-rays because, the radiation, even though it's small, it's unnecessary. So what I find it interesting, docs know me around the state. We put out a quarterly newsletter, and they'll call me and say, well, I got this person, I'm doing spirometry, and their spirometry, that's the breathing test, is reduced. What should I do? And I said, you ordered the test. What are you asking me for? There's no criteria that if your result is a little this or a little low, they can wear a respirator or not. My response is always, if you've done it, is the person having any problem wearing the respirator? If not, first of all, you didn't have to do it in the first place. But, so when I'm doing it for MSU, we're not charging because it's an in-house approval. I suppose if I was working for a private occupational health clinic, I would order all these tests, right? So I can make money for my clinic, but they're really unnecessary. I don't think I would do it anyway. But, and I think industrial hygienists who are knowledgeable in this, the other thing, OSHA says you don't have to do it annually. Yeah, OSHA says periodically. So, if I was trying to make money, I'd be in an occupational health clinic. I do all these tests and I do them annually. But we take young people when so we have criteria and we say, if you're below a certain age, you need the questionnaire every 5 years. You don't need it every year. And as people get older, we may do it every 3 years or every year, or maybe somebody who needs an SCBA, we might do that annually. But there's nothing that says this respirator testing has to be done on an annual basis. So there's a lot of cost savings available to employers that, industrial hygienists could be very wise and savvy and help when they're consulting with their companies, with different companies.
What about asbestos workers and sputum tests and things like that?
Okay, well, so, we do have certain comprehensive standards for certain, and I probably was remiss. I'm glad I'm going to talk about asbestos, but I want to say something about silica. So the concern about asbestos now is historically, we're not using asbestos anymore, but clearly there's a lot of asbestos still out there, and people may be doing renovations, and people may have been historically exposed. So there is a comprehensive OSHA, Michigan OSHA asbestos standard, requires medical screening, it requires x-ray reading. So you mentioned sputum, so that's not going to be useful. So the National Cancer Institute recommends that if somebody is at increased risk of lung cancer, which is the major condition that asbestos workers, particularly those who also smoke cigarettes or have smoked cigarettes, have a low-dose CT scan, computer tomography exam of their chest, and that they begin doing that at the age of 55, and they have it annually. So that's how we screen for lung cancer, and that's how any workers who are continuing to smoke or haven't quit smoking within the first 15 years since they smoked, and certainly anybody who has asbestosis, the scarring in their lungs from asbestos, and or asbestos and cigarettes, should be having that beginning at the age 55 on an annual basis. For many different reasons, docs aren't ordering them, workers, people, patients are not asking for them, and so there's not a lot. it's estimated, well, the studies show that maybe 10% of people who should be having lung cancer screening are having it. So it's a very small percentage, and so a lot more people. Let me say something about silica. So silica is ongoing exposure. So it is really the classical occupational lung disease. So foundries, if you look, where is silica exposure occurring? And so we still have about 100 foundries, and they are still have problems with overexposure to silica there. We now have a comprehensive silica standard. And so those individuals, if they're in areas like shakeout, they are required to have medical screening. But we have others. We have abrasive blasters. So there are lots of alternative medium to use instead of silica. Department of Transportation on our bridges, on highways, say you should use steel shot. But 40% of the abrasive, we've been following this since 1995. Back in 95, about 90% of the abrasive blasters in the state were using silica as their abrasive medium. Now it's down to 40%. So we're not there yet. We're still encouraging. Silica is cheap, relatively cheap. And the equipment for steel shot, you want to reuse a steel shot, so you got a capital expense to initiate that. But so we still have abrasive blasters, and now we haven't seen it so much in Michigan, but there's been a real outbreak with silica in terms of engineered stone countertops. So these countertops. They're like 95% silica. So it's a combination of silica and resin. They look good. Actually, my wife wanted to put them in our house, and I said, no, we'll buy the more expensive, whatever they were, because of the risk. And I just reviewing records yesterday of a 30-year-old from California who developed the advanced silicosis, which we call progressive massive fibrosis. He got bilateral lung transplants, so he's doing a little better now, but long term, he's not living to be 70. Well, knock on wood for him. But what was he doing? He was, right, you put a countertop in somebody's home, it's got to be a certain shape, a size, it's got to have a hole here. And so you're doing a lot of cutting. And he was cutting wet most of the time, and he was using a respirator most of the time, and he still got this very advanced disease. And so there have been these outbreaks in California, in Texas, along the West Coast, and then in certain countries, Spain, Israel, Western Australia, related to these engineered stone countertops. So we continue to see new uses of silica. So right, engineered stone countertop has more silica in it than a granite countertop. A granite countertop is actually safer than an engineered stone countertop.
Okay, I'll admit I have granite.
There you go. So that's good. That's safer.
And they didn't cut it in my house. They brought it cut. So.
Right, but they cut it somewhere, right?
They did. I know. And I actually went and saw it. So then it kind of relates into, so what is a B reader, and when do OSHA regulations call for the use of a B reader?
Okay, so NIOSH at some point realized we need to standardize the reading of X-rays. Radiologists are not that familiar with the classical occupational lung diseases, asbestosis, silicosis. And they originally set it up for coal. I'm not totally sure of the origin of B, but the last time I gave a talk to a group of industrial hygienists, one of them raised their hand and said B stood for black lung. So I'll take it that he knew, and right, because that's what we call coal workers' pneumoconiosis. So it's a standardized. So you have to be a licensed doctor, and you have to take a course, and then every 5 years you have to pass a test, which is not easy. A lot of people fail it. You got to pass a test every 5 years. And so the asbestos standard says it has to be somebody familiar with it. The silica standard says it has to be a B reader. So, hey, I'm a B reader. It's actually good for business, right? There's less than 200 in the country.
Wow.
So there's 6 in the state of Michigan. Um, so right when the silica standard came in, all of a sudden clinics, employers are contacting me and saying, could you do my B reading? Because they knew you have to do it. But what's nice about it is we have a standard language. So if I say a 1-1, that's an abnormal film, and everybody will know what that means. Well, not necessarily the industrial hygienist, but the other medical people will know what that means, and it standardizes it. And many times radiologists, particularly with pleural thickening, which is scarring of the lining of the lung, radiologists will miss that. So it standardizes the process. And like the silica standard has is very, it says if somebody's 1-0 or greater, then they need medical follow-up. And so it's a very good comprehensive standard.
That's good.
And I presume the new MSHA standard for silica, which I think just came out, has similar wording in relationship to medical.
Makes sense. So how does Michigan's workers' comp law address work-related lung disease?
Yeah, so I think well, we have to think about or remember is Michigan's workers' comp doesn't say work has to be the sole cause, right? So you got a cigarette smoker who has a long asbestos exposure. What workers' comp says is work has to be a significant contributor. And since we know that smoking and cigarettes interact, that's a classic example where that person is eligible for compensation because it's not, yes, smoking can cause lung cancer, but a combination is a much more likely, and I have no problem as a practitioner saying within a reasonable degree of medical certainty, if somebody has a long-term asbestos exposure, that asbestos has contributed a significant contributor. So sometimes we forget, right, workers' comp is no fault insurance. Somebody breaks their leg at work, and generally that's not contested. Maybe sometimes there's some argument when the person can come back to work. But somebody gets lung cancer, somebody gets asthma. Those are the ones that typically get contested. But again, is work a significant contributor? And really, we talked before about the OSHA PELs. It really doesn't matter whether it's below the isocyanate PEL or it's for a substance where there is no PEL, right? Because we're talking about no fault insurance. Somebody got asthma and there are certain medical criteria and it's work related and it meets those medical criteria. It doesn't matter what the standard is, right? Or what the company's level of exposure. That person's going to be eligible for workers' compensation.
So what can employers do to protect their employees? What's the employer's
Well,
responsibility?
to hire good industrial hygienists who understand,
There we go.
some of these principles. So the industrial hygienist can save the employer money on wasted medical screening that's not needed. And on the other hand, you know, look to see, what the exposures are. And I think industrial hygienists do that all the time. But don't just go by the OSHA PELs or the Michigan OSHA PELs. And you got to think about that. Yes, people can get conditions, and we always remember stories of, I remember going into a bakery and something went wrong, and you couldn't see anything because of the flour dust in the air. Well, why did that happen? And and so even when there's not a PEL for something that we know is potentially hazardous, we should be making recommendations. And I think industrial hygienists do all the time, make recommendations. The other thing, and maybe I was a little glib by the medical screening, I'm back to the asthma agents. They don't have a comprehensive standard. So employers are not necessarily doing any medical screening, but for asthma, there's very good evidence that if you can identify somebody early in on their stage of asthma and get them away from the thing they've become allergic to, they're much less likely to go on to go chronic disease. So again, I'll tell a story. I remember an auto facility where they were using isocyanates, and the policy in that facility was and I guess it was big enough that they could move somebody around. If somebody was in the isocyanate area and they had any symptoms, they sneezed once, didn't matter what they had, they could get transferred out of that area, and they didn't lose pay and they didn't lose overtime. That facility, now that's an extreme in my mind, but that facility had no cases of work-related asthma.
Okay.
They got the people away immediately, or if people had work-related asthma, they got better immediately. Then you have other facilities, they don't transfer them around. People don't get transferred till they're really sick, and then it's much less likely it's going to resolve. So I guess to summarize what I said, it's good engineering controls. I mean, we all know how difficult it is to wear a respirator all the time.
Yeah.
But you can't just go by the PELs. You got to think, beyond that box there.
Absolutely. You walk in a place and all you see is dust in the air. There's a problem.
There is a problem.
So why do you believe this topic is important to talk about?
I think it's important because what do industrial hygienists do? They measure exposure. And what are the most likely conditions, diseases? Well, lung is probably the most, I'll take the word out, probably. Lung is the most common occupational disease, right? Because the lung, we breathe in thousands of times a day. I mean, lung and skin, that's what's being exposed to well, I'll add noise too, so hearing loss, but that's what's being exposed, the direct exposure. So I think it's important that industrial hygienists remember that and help employers, deal with this issue. And some of these conditions like silica, right? I got to be exposed generally. I gave the example of the engineered stone countertops. Well, that's happening quickly, but generally you look at the foundry workers, they're not going to get their silicosis for 25, 30 years. So industrial hygienists, have to be advocates for this is a long-term issue.
Yeah.
And so that's important. And as probably the most knowledgeable people on the factory floor, they have to use that knowledge to protect workers.
And I don't normally ask this question, but you made a comment in your questionnaire. Is there any impact to a diverse workforce?
Yeah, historically, if you go back and look at our foundry industry, and it's not unique to Michigan, the foundry companies sent recruiters down to the South to recruit African Americans to work in the foundries. And they paid them well, and like Ford paid them as well as the white workers. But the blacks were given jobs in the dirty parts of the foundry. And because white workers didn't want to work in that area. Now, I'm not sure what they knew about silica at that time, but it turned out it was the areas of the foundry where people got silicosis. Mm. So if you look at people with silicosis in the state of Michigan, 40% of them are African American.
Wow.
Okay. And that represents and then once they got into the foundries, well, they were getting paid well. They could never get a job at that time that paid as well, and they weren't allowed to get promoted. I mean, I've spoken to individual patients. They couldn't get a job in a cleaner area of the foundry. They were stuck, and they weren't going to leave because they're getting paid too well. And so there were discriminatory practices to keep them in that area. And so 40%. Now, we see other issues in terms of diversity. So, for instance, work-related, but I can't give you a reason. That's a clear-cut reason. And there are papers in the labor journals explaining why it was good business sense to do what I just explained about Black workers in the foundries. But Black workers have twice as much work-related asthma as white workers. So that's something I can't give you an explanation at this point. It's something we've observed in the state, and it's something we need to look into why that's happening.
We need to protect them better, sounds like.
Yeah.
Okay, so we got to wrap this up. So have you got
Sure.
any final thoughts for me?
I thought I remembered a final thought in the past. Wait, I got to get over to my final thought. I thought I'd write that down because I thought maybe
I
you
think it
might
was
ask
about
me that
going
question.
above and beyond, I think.
But well, I just, or maybe it's my fun fact. I have a fun fact. You know, the origin of all our reporting regulations, people may not realize it, go back to the 70s when the fire retardant PBB got mixed into cattle feed. And the advisory commissions after that, there were a number of recommendations, but they were concerned that nobody knew that the workers who were making this up in St. Louis, Michigan, nobody knew what their health effects were because there was no reporting requirement. And so they instituted the occupational disease reporting regulations, came out of that fire retardant because the commission that said, why did this happen, had a broad enough perspective to say, well, the workers, if we had known about workers, maybe this wouldn't have happened to the whole general population, right? Because the whole general population got sick because the fire retardant got mixed into cattle feed, and then it went into milk, and anybody drank milk. So the whole state of Michigan was contaminated back in the 70s. So we have some of the most comprehensive reporting regulations in the state. And this is my chance to say oem.msu.edu again. Really, there's a lot there. And I know industrial hygienists who I've spoken with, they're always saying, hey, this is really good. This is good stuff. Thank you for doing this. So for those who haven't seen it, oem.msu.edu.
It is a great website and you update it all the time. So
And we do.
I think Dr. Rosenman's given us a lot to talk about and think about. So our mission with the Michigan Safety Conference is to enhance workplace health and safety by sharing EHS best practices. I'd like to thank Dr. Rosenman for sharing his expertise on the Safety Spectrum podcast, and he can be reached at rosenman@msu.edu. If you have any questions about this podcast, the Michigan Safety Conference, you'd like to be a guest or sponsor one of our podcasts, our website is michsafetyconference.org. Thank you for listening to Safety Spectrum. This is Sheila Ide.